Let's drop straight into the post-op recovery unit. We're executing a rapid-fire, uncompromisingly precise clinical review of post-operative fever management specifically calibrated for the elite 280-plus scorer. There's literally zero time to waste, so let's jump right into this explainer and master the exact clinical signatures you're going to see on the wards and on your board exams.
All right, let's look at the timeline. We are strictly anchoring every clinical presentation and every timeline violation to its specific post-op day. Timing is absolutely everything in surgery. A fever on day 1 has an entirely different underlying mechanism and a completely different management mandate than a fever on day 7.
Kicking things off with Module 1, this cytokine surge and early exudate. We're looking at the immediate postoperative window, strictly bounded by postop days 0 through 3. So, on post-op day 0, fevers are immediate threats. These are strictly driven by prior trauma, blood product transfusion reactions, or malignant hyperthermia, which, remember, is where anesthetics like halothane or succinylcholine trigger this massive calcium release right from the sarcoplasmic reticulum, and that strictly mandates IV dantrolene. But moving to post-op days 1 and 2, we hit the classic wind category. The crucial point here is that basilar alveolar collapse triggers macrophages to release pyrogenic cytokines. Think IL-1, IL-6, and TNF-alpha. And guys, this creates a massive diagnostic trap because atelectasis is generally non-infectious. It strictly demands incentive spirometry and aggressive mobilization, entirely bypassing antibiotics. Then, looking at days 3 to 5, we hit water, catheter-associated UTIs. The absolute mandate here is pulling that Foley catheter as early as possible. This brilliantly illustrates the clinical variants we need to watch out for. You've got to differentiate between a benign cytokine surge and a true infection. Atelectasis, that's a self-limiting response on POD 1 and 2, without distinct infiltrates on imaging. Aspiration pneumonia, on the other hand, presents with strict dependent lobe infiltrates and severe hypoxemia. That mandates immediate broad-spectrum coverage, like clindamycin or unacin. Whatever you do, don't let the early timeline lull you into missing a true pulmonary infection. Moving right along to Module 2, the thrombogenic and tissue matrix. We're going to see how this builds into the midweek timeline, spanning post-op days 4 through 7. Remember, surgical trauma maximally amplifies Virchow's triad. So for post-op days 4 through 6, we're looking at the walking category, DVT and PE. The clinical signature here is unilateral extremity edema or sudden onset tachycardia and hypoxemia. This strictly demands low molecular weight heparin prophylaxis unless there are neurosurgical or bleeding contraindications. Next up, days 5 through 7, we evaluate the wound. Surgical site infections are driven strictly by skin flora like SRS or bowel flora like E. coli. They're going to present with erythema, induration, and purulent drainage. Your management mandate: open the wound, pack it at the bedside, and let it heal by secondary intention. Now listen up, because this is where you earn that elite score. We have to talk about the necrotizing exception. If a wound infection presents prematurely on post-op date 1 or 2 with extreme pain, crepitus, and dishwater exudate, that is strictly a timeline violation. It is necrotizing fasciitis. It's often driven by group A strep or a polymicrobial source, and it mandates an immediate return to the operating room. Broad-spectrum antibiotics alone are simply not going to save this patient. Let's progress to Module 3, the deep cavity and pharmacologic traps. Looking at post-op day 7 and beyond, our focus shifts over to occult reservoirs and hypersensitivity reactions. For post-op day 7 and beyond, wonder or where points us straight to deep space infections. We're thinking anastomotic leaks, intra-abdominal abscesses, or even C. diff colitis. But you also have to consider wonder drugs. Pharmacologic favor from antibiotics or heparin is strictly a diagnosis of exclusion. In these cases, peripheral eosinophilia might literally be your only absolute clinical clue that the fever is immune-mediated rather than infectious. You have got to quickly distinguish between a superficial SSI and a deep cavity disaster. A superficial SSI is just managed at the bedside. But an anastomotic leak, which you'll typically see after a bowel resection, presents with peritonitis, severe tachycardia, and total hemodynamic collapse. This clinical signature dictates an emergent CT scan with rectal contrast and an immediate exploratory laparotomy. No exceptions. All right, time to transition from passive review to active diagnosis with the master case, testing the nuance. We're going to test a deep integration simulation based on our exact blueprint to really put these timeline rules to the test. Okay, here's your master case blueprint. We've got a 65-year-old diabetic male on post-op day 2, following an elective exploratory laparotomy. He spikes a fever of 102.5 Fahrenheit and complains of severe, unrelenting abdominal pain. Now, the prompt provides mild baseline tachypnea and slightly decreased breath sounds at the lung bases. Why? To aggressively tempt you into diagnosing benign atelectasis based purely on that POD2 timeline. But look closely at the physical exam. Extreme incisional tenderness extending way beyond the wound margins and subtle skin crepitus. What is your next step? Notice how the clinical presentation here perfectly mirrors our master case blueprint. We have a diabetic patient with a puncture wound showing exquisitely tender surrounding erythema. The physical exam findings of extreme tenderness out of proportion to the visible injury, combined with that crepitus, are absolute timeline violations. They must force you to bypass chest x-rays entirely. Seriously, don't get distracted by the mild tachycardia. You're looking at a masked, lethal surgical emergency. And this source analysis right here definitively confirms our approach. Necrotizing soft tissue infections progress incredibly fast. The educational objective explicitly points out that broad-spectrum antibiotics in fluid resuscitation alone are totally insufficient, carrying a massive mortality rate. Because this is a rapidly spreading infection involving the subcutaneous fascia, aggressive operative intervention is the only definitive therapy. Let's execute an exhaustive breakdown of our 5 distinct choices for the next step in management, starting with option A, hyperbaric oxygen therapy. This is strictly reserved for chronic, non-healing wounds, not an acute septic shock scenario. Moving to option B, tetanus immune globulin. That's preventative for grossly dirty wounds in unimmunized patients. It definitely does not treat an active necrotizing infection. Next up is option C, negative pressure wound therapy. Great for facilitating healing in open wounds, but entirely inappropriate for an acutely ill patient with intact skin overlying necrotizing fascia. Then we've got option D, incision and drainage with local anesthesia. Sure, that's fine for small fluid collections or superficial abscesses, but it'll grossly underestimate the depth and rapid spread of this disease. Which leaves us with option E, emergent surgical exploration and debridement under general anesthesia. This is the absolute mandate. You must forcefully select this option, recognizing that critical timeline violation of necrotizing fasciitis.
As you prepare for the words in your board exams, I want you to internalize this single rule. Always ask yourself, does the clinical signature actually match the anticipated timeline, or is a masked timeline violation hiding a lethal emergency right in front of your face? Don't let a classic Day 2 presentation blind you to an exam finding of crepitus. Trust your physical exam over the calendar. Keep pushing your clinical reasoning, and I'll see you in the next explainer.